Hello students, today we will discuss a postoperative situation. Just see what this postoperative look is. Look at that. See, that is the proximal part, is the distal part. There is a wound here, laparotomy scar, midline, and there is a stoma here. What is stoma here? Protruding, something protruding, bowel. So what is this? This is ileostomy stoma in the right iliac fossa, ileostomy stoma. So what are the indications? Mainly whenever left-sided surgery you do for malignancy, for obstruction, sigmoid volvulus, acute conditions where primary anastomosis is dangerous because leak can occur and not feasible because of the critical condition of the patient, then you will do a diversion, what is called as ileostomy. After rotocolectomy also you will do diversion if you are planning for the maintenance of continuity with the different J loop, that W or S, whatever later period, you have to do a stoma. So it's mainly a diversion procedure, sometimes commonly temporary, sometimes permanent, and that is usually done in the radial fossa through the rectus muscle. Anterior rectus is opened, incised, and rectus muscle split or retracted. Then posterior rectus is opened in the radial fossa, usually in the middle of the spinal umbilical line, and bowel loop and intestinal loop, ileum, usually 5 cm proximal to the ileocecal junction. Loop is brought out and loop is incised, and 3-4 sutures are loop. Seromuscular suture is fixed to the anterior rectus sheath. Then everted opened bowel small intestine is sutured to the skin, and usually we will do a inverting suture, what is called nippling of the ileostomy stoma. Also that will prevent the receding of the ileostomy stoma into the deeper plane in due course of the time. So that is how exactly you will do the ileostomy. Usually can be done under spinal anesthesia, or it is usually done under general anesthesia as a continuation procedure of the resection or whatever surgery in the distal aspect as such. Now it can be loop, it can be end, depending on the situation. Surgeon will take the call, and usually it is closed once everything is settled, inflammation, infection, sepsis, general condition become better, or if it is a malignancy, after proper adjuvant therapy and everything is settled, surgeons or oncologists satisfy that patient is disease free, then only you will close. Don't hurry to close the stoma. As much as possible, delay it until everything is settled. That's very, very important. Otherwise, closure of the stoma will cause further problem. Early closure of stoma, unnecessarily. Hurrying the closure of stoma is not good. So that is counterindications, short mesentery and carcinomatosis, types loop and end. And these are the complications: stenosis, prolapse, obstruction, parastomal hernia, bleeding from the surface, hematoma. Skin excavation is very, very common. Of course, you got a good stoma bag now, so skin excavation is avoided with such current available stoma bags as such. Dehydration, electrolyte imbalance is common because in the ileum, so a lot of fluid output comes through the stoma, and prolapse of the mucosal prolapse or stomal prolapse is also quite common as a complication of the ileostomy. So that is about ileostomy. So please go through my clinical methods in surgery and manual of surgery. Details about ileostomy. Operative procedure shows how to do ileostomy, how to close ileostomy also, and you can go through the detailed technical aspect, and you can go through my DigiNow lecture through JP for all this ileostomy, colon disease, small bowel disease also. So students, I hope you understood a small topic, very important topic, asked as a short note in the exam, and why also they may ask, MCQs they can be asked, that is ileostomy, always placed done commonly, otherwise the commonly done is in the right iliac fossa through the rectus abdominis muscle. So students, you understood this topic very well. Thank you very much.